I'm very excited for this session, for this new revolutionary technology. We're going to talk about mainly SEISMIQ IVL, which is just a different type of IVL, new and exciting type that we're going to talk about some of the basic science of it, where it originates from, how those pressure waves are generated, and then we're going to show you some case examples, and then we're going to also go through some examples of Jetstream Atherectomy, one of my favorite atherectomy devices, along with drug elution, and how we sort of marry those technologies. Have a great faculty here. We have Dr. Golzar, cardiology. We have Dr. Noor from vascular surgery. We have Dr. Dua, vascular surgery. And we have Dr. Nair, cardiology, and I'm the lone IR, I guess, up here. So we have a nice multidisciplinary team here with vast amount of experience to take you through things. So I'm going to start off with Dr. Noor is going to take us through a little bit of some of the mechanism of action of the SEISMIQ device and how it works and what the console looks like if you haven't had your hands on it or have seen it yet. So, Dr. Noor, why don't you take us away?
Thank you. Good morning. So, my story is I've been using Shockwave. We all have. And Boston Scientific got this new catheter, and I was like, I want to get my hands on it. I want to get my hands on it. Can you please, somebody please give me a console? Can I please get my hands on it? So finally, last week, I used it. So now I feel like an expert, and I can actually talk to you about what I saw. So the way I looked at it is we've been using Shockwave for, I don't know, many years, like 4 or 5 years. And certainly in my practice, aortoiliac disease, it has been significantly a game changer. So what I'm going to say about SEISMIQ with my N of 1 is I think it's a smarter, more precise shockwave. And we'll go over what we see. So the way it works is it's laser-based as opposed to electrical-based, which is what shockwave is, which means there's less degeneration of the signal of the transmitters across. So basically it's laser energy, hits the metallic target, which is the emitter, which then has a pressure wave generated, and then a secondary cavitation balloon, which is basically layman's terms for generates enough force with sonic waves to be able to crack the plaque, as you can see. What I like about it, and I thought I'd highlight that, is I think it's more deliverable than the shockwave balloons are. So if you guys, those of you who use shockwave, after one inflation, it's really hard to get it to move up and down. And specifically what I found with this balloon is I thought the trackability was much better. Then the emitters are like a spiral on the balloon, so it gives you a little bit more of precision where you can direct it, which I liked. And what it's not mentioned here is you can see it really well. So that to me was a really super advantage. Then I'll go over the emitter in a second. So there's a difference with the console on what you see and the feedback it gives you. And you get a better understanding of how you're treating the disease, which the current shockwave does not give you. So in terms of the emitters, it's arranged as a spiral along the catheter. There's 5 of them. They all have the same amount of energy. And basically, when you turn them on or off, you can turn them on, you can decide which ones you want to turn on, and then you can rotate them because they look like an H or an I, and you can decide if you have a really bad lesion and you want to work on that one for a little bit longer, you can actually do that. So generally, it's the other thing that this slide doesn't say, it's a 15-second cycle, so it's a little bit shorter than shockwave would be. You can then decide whether you want to turn on the middle 3 or the end 2, depending on what your lesion looks like. And as you're doing this, you're actually getting active feedback on the console. So there's this massive screen that you're looking at. So what it's telling you is at the very top, it's telling you how many cycles there are. It's telling you how many pulses are left. It's telling you at the bottom how many pulses are left. And then I think the biggest thing for me was as I inflated it and I got up to, let's say, 4 atmospheres, because you're really not doing a balloon angioplasty where you're cracking the plaque. You get it up to profile so it's touching the wall of the vessel. You turn it on, and slowly, your atmospheric pressure starts to drop because the vessel's becoming a little bit more compliant. Now you can decide based on the lesion, do I want to do this area a couple more times? Do I want to change my catheter? And then the best part that's not on the slide because, sorry, marketing, there's no setup, guys. There's no like sterile setup. So literally it's a plug and play. So you get the catheter off the table, take it off, prep it, boom, ready to go. Which, time is money. You want to be able to do that. So my experience was it was a smarter shockwave. It was more precise, it was trackable. I saved time, and it gave me a lot of real-time feedback. So I am excited about using it and looking forward to hearing about what everybody else has to say. Thank you.
Thank you, Sonia. One quick thing I forgot to mention was you guys have little QR codes at your tables, so please, if you have any questions, it'll come up here to our faculty. If you scan that QR code, you can just text in questions. So.
Thank you so much. Thank you for the opportunity for being here, and I'm honored that you guys all showed up actually to see us this early in the morning. So we acquired, we also were shock waivers, and then we acquired SEISMIQ about 6 months ago. So we've had about 6 months of experience doing it, and I'm gonna present a SEISMIQ and Eluvia case. So, you know, when they were talking to me about it, they're like, hey, do you do DCB, DES? I'm gonna kind of go through my algorithm on how I treat these patients. And this isn't the most complex patient. It's probably actually a pretty easy patient that we're gonna talk about, but I'll just kind of quickly go through my algorithm, how I use the technology, and sort of some tips and tricks. So 48-year-old male, peripheral arterial disease, lifestyle-limiting claudication, Rutherford class 3 symptoms, failed conservative therapy, blah, 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 you know, all that. Okay, so what did we find? So we found that pre-procedure angiogram showed a left SFA CTO, but this is the important thing, is you're gonna see a very elusive cap. So whenever I talk about crossing CTOs, or the predictability of being able to cross a CTO, there's three things that I talk about: the proximal cap morphology, distal cap morphology, and the amount of calcification. So you may have noticed the one thing I left out of that was the length of the CTO, because you guys have probably all been in the situation, you can have a CTO like this that takes you 5 hours, you know, an hour and a half, and then you can't get through and you're subintimal, or you can have a 300 millimeter CTO that you cross in 30 seconds. So I never include the length of it. So here you can see, I apologize, the angiogram is a little light, but that's where the SFA CTO is. You can tell just above the level of the adductor canal on the left. And then you can see that proximal cap is very elusive. So it dives right into a collateral branch. So here you have an issue, because what's gonna happen is if you use a hydrophilic wire, like a glide wire V18, all it's gonna do is get into that collateral branch. So what you need is one of two options. You either need a non-hydrophilic wire, like a Treasure 12 or an Estado, that can really penetrate into that cap, or pedal access. So we tried it with an Estado, couldn't really grab that proximal cap. So we were able to, we got pedal access with retrograde. And the way I do it, I had a V18 from the back, from the bottom. I go up, I balloon my channel with an undersized balloon. I don't snare my wire. I go up, balloon my channel with an undersized balloon, and then just rewire with my antigrade wire. I like to work antigrade. So here you see a V18 018 quick 018 Navi going down. So we've already gone retrograde with the wire, and you could tell that distal cap was a little bit more, was a little less hostile. So we were able to cross it. Now we're working antigrade. So now, let's get to lithotripsy. So why do I do lithotripsy? So I do any kind of vessel prep that I need to do in order to deliver drug. That's the most important thing for me, is delivering drug to improve durability, long-term patency. So from my standpoint, whether it be orbital atherectomy, you know, whatever I do, orbital atherectomy, directional atherectomy, lithotripsy, I'm doing all of that to debulk the plaque, and allow for drug delivery. Because as you know, where does the drug work? It doesn't work in the intima, it works in the adventitia. So you need to create these fissures, you need to create, you know, remove some of the bulk of that plaque so your drug can go into the adventitia. So here on the left, you see the initial dilation. So as Sonia mentioned, the two really fun things about this technology are you can see where the emitters are oriented, and you can specifically select one emitter so that you're not burning through all your pulses. And it's probably happened to all of us where, you know, you have a long SFA CTO and you use shock wave, and now you're like, oh shoot, I'm screwed because I have no more shocks left, you know, so this has 600. So the way I do it is I take it up to the lowest atmosphere possible, and I hit my entire lesion with the lithotripsy. And so the reason I go low pressure is that helps me identify where is the actual calcium. So as you can see up here, it's expanded nicely. Down here is expanded nicely. In the proximal segment, it hasn't. That tells me that's where my calcium is. So I'll do my first hit with all of them, and then what I'll do, just for fun, is I will tailor my delivery of shocks right there in, that's gonna be A, B, C, D, E, in E. So turn off the rest of them and just deliver shocks into E. And then what I do is, as I'm delivering my shot, so I start at 1, so I do the first one, nothing, just the whole thing, and then the second one I do targeted delivery, and then as I am, oh shoot, I knew I was gonna do that. Could you go back one?
You can go.
Oh, this one?
This little guy. Yeah.
Okay. So then what I do is, as I'm so I dilate it up to about 1 or 2, and then as I'm delivering therapy, I continue to go up on the balloon. Oh, it's not playing. Yeah, that one is playing, the one on the right. Yeah, there we go. So here, the fun thing about it, see, we're kind of a little bit off on the left screen. You can see that the emitter is a little bit off. So all you got to do is just move that baby up a little bit, and we put it right on where it is, and you see it pop. So that's the beauty of this technology. You're not just burning and wasting through the, you're not wasting the pulses. And so now I've vessel prepped. So my algorithm is then either if there's flow-limiting dissection or residual stenosis, drug-eluting stent. If there's no flow-limiting dissection or residual stenosis, then drug-coated balloon. And so here you see on the left-hand side, you can see probably the proximal cap was here, where we went probably subintimal, here subintimal. And so you see this dissection looks kind of gnarly and ugly. And so we delivered Eluvia drug-eluting stents, 2 70150s, I believe. And you see the final angiogram. So in summary, it's another tool in our toolbox. I believe the advantages are you get much more visibility of the emitters. You have the ability to focus your emitters, and so therefore not using pulses. And then you also have the higher pulses that you don't have with alternative therapy. So thank you so much.
Thanks. That's a great case. I love that you showed the repositioning there, and you said two things that I love and I do myself. One, I hate snares. I think people spend entirely too much time with snares. Like, all you need to do is just do a good cart and have good tactile feedback on your wire and advance your wire. Why are we spending time snaring for Twitter or something? I'm not sure why. So that's just a waste of time and money, in my opinion, 90% of the time. And two, I love the pulse preservation thing, and where you inflate, kind of very low, and then you kind of choose where you want it. So I'm going to take us through a case that I just recently did. She's 89, and I've taken care of this lady for several years, actually. She's got the usual risk factors, and actually I did an EVAR on her in 2022, which means I have to go antegrade because I did a GOR excluder on her. And just following her, for her usual PAD and her aneurysm, and she presents to me with a 3-month history of a non-healing ulceration to her left medial ankle. So she's got like a mixed arteriovenous wound, but it's not really granulating. It looks a ischemic component. Getting Una boots, and shockingly, that was making it worse. ABIs I apparently don't have listed, but it was like 0.4-ish ABI. This is what her leg looks like. It was a little red. It's not happy. She's in pain. She's hanging it down. But again, medial ankle wound. This is what her CTA looks like. Actually, the great thing was her aneurysm used to be 6 centimeters. Now it's like nothing, right? It's like totally dialed itself down. And if you come down here, she's got severe calcium right throughout. So I got to go antegrade. The problem here, the reason I showed the CTA is, I don't know if you can appreciate that, the SFA origin also has like a rock at it. It's not occlusive, but it's, I got to go antegrade, and it's an origin rock, and then she's got a CTO right at the adductor, and you see extreme calcium there into the pop. So I had to stick. The antegrade access was a little annoying, right? Because I had to stick and then wire into, with 1 centimeter of purchase, wire through the SFA stenosis. And then my plan was then to cross the FemPop CTO. Hopefully I could do it antegrade. If not, get retrograde access. I thought I would get retrograde access regardless because I need to treat that SFA origin lesion. So I was thinking, you know what? I'm gonna use IVL for this. It'll be great. It's not a great stent spot, so I thought it was a great IVL case, and I'll get retrograde access and treat that, and then plus or minus, for the CTO, placing Eluvia. She's 89. It's going to do really well. I don't really want to be bringing her back at 91 for her DCB recoil or something. So I'm like, let's just get it taken care of. So that was the plan. So here's my access. You can see that SFA origin lesion now pretty well. I tried to get high enough access where I didn't cause her a retroperitoneal hematoma, but high enough where I could actually steer and get a picture. You can see down here, she's got a TKA with a rod there, but you can see that her distal adductor, just beyond the adductor, it occludes, and then you can see in that final image where we come back into P1. So not a super long lesion. It might have been about 10 centimeters or so, but to Jafar's point, that could be brutal. And actually, as it turns out, her, and this is her runoff, she had a PT dominant runoff. There's a perineal that came back, but no AT. This is what it looked like. I couldn't fully, I actually got purchase. I used a weighted tip wire, like you had mentioned, just to get into the thing. The cap was super tough. I pre-dilated that. That's what you see in that first image. But I could not, then I was in some deeper dissection plane than I like. A lot of times I get retrograde access just because I don't like the trajectory I'm going from the antegrade plane. Sometimes you just take a better plane. And in this case, I know I needed it anyway. So we accessed her PT. We came back up. We performed a cart. It's hard with this hardware, right? But you could see that that's my retrograde balloon. So I was able to get up. My wire actually found, because I had pre-dilated above, my wire found that plane from above. And then I dilate from below, and just like you said, there's no need to snare, right? I'm just going to balloon that and then advance my antegrade wire down. We did that. I used a 660 SEISMIQ, and yeah, there are a couple things about the SEISMIQ that's great. Is one, you have the directionality. Two, you have the selectivity of the emitters, right? So I do exactly what you do, a very low pressure inflation on that, just to get wall apposition, and then I see where my issue is, right? And then I turn off the other emitters because you don't need them. And in this case, I know I needed those emitters for up top. So I was able to turn off those other emitters, save my pulses, and just use them where I needed them, which in this case was the proximal cap. And this is really, yeah, exactly. So I can turn that off, and in this case, for me, this was E, just similar to your case. This was E, where the prox was really the issue. So I just leave E on, and the nice thing about this unit is it's so nice. That you can see how many pulses you have left at each emitter. You can see your total, pulses as it goes. So it's very obvious. It's very user friendly, and so that's what we did. So I used it where we needed it. I guess in this case it was more like D and E. So I kind of left those, but I saved my pulses at those other emitters. For the reference, the emitters start like A is like the distal emitter. So I had to learn that. I figured that out after a couple of uses. But the A is distal, so E is like the top emitter. And then I followed that with an Eluvia, and it had a really nice result. And I thought, there's still, even despite all that, there's still some mild residual stenosis. So I was like, okay, we're definitely going to place a scaffold here. But talking about deliverability with this, I was impressed because I've used Shockwave for years, and the fact that I was able to wire alongside a pre-used balloon from the PT access alongside my 6 French antegrade sheath along that SFA origin lesion says something. Honestly, I was like, I don't know if this is going to go or not, but it went actually pretty easily. So I think the trackability on this is definitely superior. So we retrograde wired beyond that, into the iliacs, and then I used the remaining, pulses from the other emitters, and we ended up with a extremely nice result. She had palpable pulse. This was a recent case because I only got my unit about a month ago, but she's been doing extremely well. She continues with wound care, and her rest pains. My nurses do their follow-up calls, and they said she instantly, feels better. So I thought that was a good example of a couple advantages to the SEISMIQ. Thanks.
Little discussion about IVL. So from my perspective, I think we're heading now more towards a precision-based IVL therapy, and this is kind of like where the field's going. We have various technologies that are emerging now, and this seems to be the new play in this entire field, in this space. I mean, where do you think we're going? I mean, are we going to be able to start dealing with nodular calcium? That's always been the battle, the challenge of treating these lesions. What do you guys think?
I'll speak to it briefly. I think the selectivity is huge. I think the other thing that we didn't maybe highlight as much is that because of the way those the emitters are oriented and that H and I design, you have directionality as well as selectivity, right? So if you go almost like, you think about your Outback or your re-entry device, right? If you go to orthogonal planes and you get that H, you're coming off at 180 degrees to that, or is it 90 degrees to that? I don't know. But the bottom line is you go to an orthogonal plane and you're going to see those two emitters. You're going to come off right at a right angle, to that for your pulses. So because they're radially arranged, you can advance your balloon to the point where where you need to deliver the pulse to that. You can see where the calcium is, and then you can literally advance it to that emitter where you're going to have directionality. So I think it is a step forward in treating nodular calcium, like you're saying, because you have two things now that we don't really have before. I mean, you could theoretically do that with shockwave, but you actually don't know, and they are radially arranged, by the way, but you don't actually know where the emitter is delivering that pulse.
Yeah, thank you for that question. And, I kind of started my talk saying this is another tool in our toolbox, and I truly believe that. So, when I look at calcium, I look at mountains, these peaks that you see, as well as hills, the smooth ones. This lithotripsy works really, really well for those smooth, those hills. But for those mountains, it really doesn't. And so that's where you still need your orbital atherectomy. You still need these, maybe you have still residual stenosis after that. You need a high radial force stent to follow, like a supera stent. So again, another incredible tool in our toolbox. But remember, that's what I love this field, is there's no one device that covers everything, right? That's why we get to play with all these new devices.
I did have another question because the three of you have more experience with SEISMIQ than me for sure, and I'm looking forward to being like you, Sonia, and getting my hands on it. I have some of my people here watching, so we'll be talking about it. But can you talk a little bit about the specs on it, like the diameters that are available, any like shaft lengths of the device? I'm just curious if you can relay some of that information.
I think the smallest is 3. I think that's our smallest. They're always come in 60, and I believe the smallest is 3, right? And it goes up to maybe 7-ish. It's not I can't remember the shaft length. I don't know.
I think it's 140.
Is it 140?
Yeah.
Yeah.
140.
It's meant for to go up and over. I think it's 3.5 by 60. All of the balloons are 60, and it goes up. So it's basically a fempop aeroiliac kind of balloon. We don't have a tibial one, and I think the big highlight for me is all that some of those vessels that have the medial calcification that you really cannot change the compliance on would really get your pulsatility back, would get your blood flow to go back to normal, let's say, like a reset. I think this now has the ability to do that. And then drug, delivery after that medial calcification has been broken up, which is where the drug should go, I think is going to make a big difference. So it's not just like a smarter shockwave, it's actually a better shockwave, because it's now allowing you to kind of decide precisely where you want to go and then deliver your drug.
Yeah, I think, and the one thing with the laser-based, lithotripsy, right, is it does give downstream options for whereas shockwaves, electrical current-based, and you have to add more wires and emitters and stuff, and so that's where that trackability becomes an issue, as well as balloon length. I think, of course, this is the first iteration of this, but I think we're going to see. Of course, they just released it, but I already want something better. But I think we're going to see longer balloon lengths, smaller sizes, because of this the difference in the way that cavitation wave is created.
I don't think this one is working. So I'll borrow your. So, one of the big things I think that we shouldn't go past is this amazing thing you said about the deliverability. I don't remember the last time I used shockwave without having to pre-dilate first. Every time I'm pulling, usually Serenity balloons or sometimes the Serenity, anything to get that luminous. And then you wonder, because it's not really meant for that, right? So once you've disrupted and then you use shockwave, does it have the same effect? I don't know. I've already pre-dilated. If I were to just pre-dilate more, would I get the same effect? But now, with the deliverability aspect, and then I will say certainly where I work, it's like 50 first dates. Every time's the first time when we pull shockwave. But getting everything set up. So the idea of plug and play, I think, is a really big deal. We don't talk about that enough when we talk at these. We just talk about the benefits of the actual device, but time saving and deliverability is a huge thing.
Speaking about time saving, one other thing I'll mention that we didn't talk about is that dead time between pulses also, how you finish the shockwave pulses, and I didn't even know this until I started using it. You actually, because it beeps out, to let you know, hey, you finished the pulse thing, but you can literally just hit the button again. There's no regenerate, and I don't know what that time window is for shockwave, but it feels like about 3 hours, but it's probably about 20 seconds. But you don't have to do that with this. It's ready to go again.
And Pradeep, while you're getting up there, one other advantage of lithotripsy in general are those cases where you go subintimal, right? Subintimal tracking and reentry. You can't really do directional atherectomy. You can't really do orbital atherectomy. And so in those cases that you're subintimal, lithotripsy in itself is really, really helpful, because it'll penetrate through.
Yeah, I think anytime you are thinking of a stent strategy, we need to pre-dilate Supera stents, Eluvia stents, whatever stent, we got to pre-dilate. IVL is going to be huge in that area. All right, so I'm going to move on. So I'm really impressed. So welcome to all of you. Good morning. It's great to see such a big group this early in the morning after a festive night last night. And what I'm going to talk about is Jetstream and Eluvia. It's kind of interesting because it's bringing me back in time. This is a case that we did at NCVH in 2023. This was a patient, Nick, you were on the panel, and Sonia, you were on the panel. I remember this. It was a Boston Scientific Symposium at NCVH. It was an 85-year-old female. She had type 2 diabetes mellitus, stage 3 chronic kidney disease, hypertension. She had the wounds that you can see here. Her left SFA and popliteal were occluded, one vessel runoff to the foot via the anterior tibial artery. And these were her, and if anybody's interested in actually watching the case, it's actually online. You can actually see the case. But this was the image. So her SFA was occluded, and you can see that it was starting to reconstitute into a very diseased P2 segment of the popliteal artery. And the anterior tibial was our only single vessel that was going to her foot. And so when I was looking at this case for NCVH when we were doing it, the game plan was we were going to put a sheath. It was going to be a 7 French sheath. We were going to use intravascular ultrasound is a technology that I highly recommend, even with IVL, when you're thinking about IVL, to understand the size of your vessel so that you can size your balloon to the vessel appropriately. But we use precision-based guidance for treating these types of vessels. Now, with a single vessel runoff in Jetstream Atherectomy, I opted for a filter. And I think anytime you're thinking about a filter, it's probably best to just put a filter. Jetstream Atherectomy has the beauty of being able to do rotational atherectomy to debulk the plaque, but also aspirates at the same time. But that being said, in CLI, thrombus is ubiquitous. You're going to see some form of thrombus somewhere along the way, even though the vessel's calcified. So in this case, we used a Jetstream XC 2.4, 3.4 system. And then the game plan was we ended up treating with Eluvia stents and we used Ranger. But I'm going to show you a couple of things. Now, I don't know how to play this. I think this is a touch screen. So this is the IVUS run. So after we were able to cross, you can see that we were in the true lumen of the vessel, and you can see all of the calcification within the vessel wall. I don't know if I can speed this up, but let's just let it run. It's always good to look at IVUS. The image quality with the intravascular ultrasound with Boston is extremely good. I mean, we can get excellent definition of the vessel, excellent evaluation of the plaque. You can see mixed plaque morphology, extremely stenotic disease, and the calcium. So you see kind of like the full spectrum of disease or plaque within one lesion. So in this case, I'm in the true lumen. This is the bottom line. I'm in the true lumen after the cross, and we are opting for atherectomy. If I was truly subintimal, we were talking on the panel about that Jetstream, in some cases, subintimal utilization with blades down. So Jetstream has the ability of going blades down or blades up. If you're subintimal in a short area, blades down is okay, or you can even pass it and then move forward. So let me get to the next slide. So this was the Jetstream that we were able to do. The picture on the right is after we made our passes, 2 blades down runs. Now, I could have gone blades up, but I was being a little bit cautious with this lady. And so that's a channel that you're able to create simply with the Jetstream atherectomy system. And you can see my filter. There may be a little bit of thrombus at the very, or debris at the very tip of that spider filter. So just be cautious in single vessel runoff patients. I think it's always good to be protecting your patients in that scenario. But thrombus, distal emboli should always be on your mind. So in this case, we used a Sterling balloon. We dilated with a 6 millimeter. We sized it 1-to-1 with the intravascular ultrasound. You can see a dissection around the P2, P3 junction distally. From there, we opted to treat with the Eluvia. Now, I'm going to be honest and state that I am always the guy that is hesitant with self-expanding nitinol stents in the popliteal segment. And I was always curious, are you going to get fractures? Because I've dealt with so many fractures in this segment, and it's a nightmare at times. But what I can tell you, and I'm going to show you an example here, is that the Eluvia stent really is very durable. This was an elderly female, too. She wasn't running marathons. She wasn't going to be highly active, but she was active enough. And so it was on my mind. But we used 2 overlapping Eluvia stents that we were able to get a good result there. And then the question was proximally, what do you do, right? Do you just continue to layer a full metal jacket? Do you use Ranger drug-coated balloon? In this case, I opted for drug elution Ranger. There was no flow-limiting dissections. I used IVUS again to help us dictate what we want to do. And then finally, we were able to get restore flow and get her foot a flow that she needed for healing. 1 year later, she still developed, had another wound that you can see here. So we brought her back to the lab, and you can see. Now we're in 2024 angiogram. This patient's had the Ranger drug-coated balloon. You can see wide patency. You can see in the Eluvia section, there's wide patency. And you can see there was an area of stenotic disease. It was right in the P3 segment that you can see, and you would not be able to detect this perhaps angiographically, but if you use intravascular ultrasound, you can clearly see that there's disease. So I opted to simply treat the distal pop into the AT, and I use a Ranger drug-coated balloon. And again, this patient was able to then get flow restored. So now we went from 2023 into the current status. This patient is now completely healed and doing well. So the take-home messages that I want to bring out is that Jetstream atherectomy allows for plaque modification and debulking with aspiration to help us optimize, as Jaffer was saying, to the therapy, to help modify plaque so that we can get good vessel expansion and also help with drug delivery. And one thing I can tell you about Boston Scientific is that they do a phenomenal job with their clinical trial programs. And really, this is a case for me that shows what their clinical trial programs does in the real world. This was a case that may not have been a candidate for some of the clinical trials, but we can translate what we have learned from those very prominent trials with Ranger drug-coated balloon, for example, Ranger 2, SFA, showing excellent patency long-term. We see that in this patient. Eluvia, drug-eluting stents, we see from Imperial, Eminent trials with excellent patency that we can translate that to this patient that I showed you today. And so, Eluvia, indicated for the SFA proximal popliteal segment, and this case really demonstrates its durability and resistance to fracture and how we can use it in calcified vessels. And again, I'm an IVUS utilizer, and I highly recommend IVUS be considered in the algorithm of treating these patients. Thanks.
That's an awesome. I love that case for about 10 different reasons, but I remember that case, and it was a great case, and I remember congratulating you for undertaking it because it was a difficult case to do live, but you had a great result. I have two comments on it that I want to bring up, and then I have a few questions from the audience I also want to give to the panel. I love that you used the DES there over the woven nitinol, and I love that we have follow-up to show that that can be a viable, and not only a viable, a great strategy for that patient. I think too often we get caught up with that, in the P1, P2 segment, and we worry about it. Sometimes drug is better than the stent architecture, and so I think we need to ask ourselves more often than I think people do, because we've kind of got it ingrained in our brains, like, oh, well, you can't use it there. And I would say, as the years go on, I use more Eluvia in that space than I did previously year over year, because it actually performs well, and I haven't really been burned on it, to be honest with you. So I don't know if you could speak to that. Has that become your practice?
Woven nitinol stents in that segment has always been my thought process. But if I'm going to use a nitinol self-expanding stent, it is going to have drug elution capabilities, and it's going to be an Eluvia, period. Full stop.
I'm still a little squirmish on putting a nitinol stent in the pop, but I mean, this is why I love coming to conferences, right? Because you learn from your peers and your colleagues. I usually do, if I'm going to cover the pop, I usually do the poor man's DES, where I drop a drug-coated balloon first, and then follow it with a superior stent, nitinol woven stent. So that's kind of what I do. But one more thing, I'm really glad, Pradeep, that you brought up this whole issue with filters, because even in 2026, I think on the podium, it's a 50-50 split, right? And they say, well, you don't have to use it, you do have to use it. And then I'll even take it a step further than what you said, Pradeep, which was, especially single vessel runoff. I'm like, even if it's 3 vessel runoff, if you have that one embolization, you're going to chase it, no matter if it's a 1 vessel runoff, 2 vessel runoff, 3 vessel. So, ounce of prevention is worth a pound of cure. Just do it.
Yeah, no, you can't. I can't agree more. I mean, that's. We do so many procedures, and we hope for everything to go perfectly well. But despite that, I think we need to put a bigger emphasis on loss of vessels distally. I mean, the microvessels get embolic debris. We can lose these vessels, so we have to start thinking about that. Yeah.
Real quick, I just want to take a couple questions from the audience. Is that okay before I delay your case even further? No. The question was, with heavy calcium and plaque burden, is there a benefit to atherectomy prior to using SEISMIQ? If you have heavy calcium, I'll open it to the panel.
I've thought about that, like if we have a lot of diffuse calcium up and down, and the balloon is limited to how many cycles you can do, like it's, let's say, a 20 millimeter lesion. I am a big rotoblader fan, so it allows you to do not only, let's say, the tibials with the same device, you can actually move it up the leg and you can do it, because really at that point all you're trying to do in the SFA is create a lumen. So my tibial was taken care of, let's say, or the distal pop was taken care of with the rotoblader, probably not well enough up top. So those are the cases that I'm thinking about. Well, now I add a SEISMIQ to it. and I'm able to treat the top effectively, a little bit more effectively, and then decide kind of what I want to do. What we didn't talk about is the OBL codes, which we should get into maybe after. So it now allows me to actually treat my patient a little bit better because that is now available to me as well, and it doesn't hurt me economically.
Yeah, no, it's a good point. And there's, OBL codes this year now for iliac and FemPop. We still don't have codes for BTK. Also, I don't know that we have ideal balloon lengths for BTK. So for me, currently, IVL is a problem solver down there. It's not that I don't use it. I use it as a problem solver. But atherectomy still plays a big role for me in BTK, and that's really where I see it. That's when I'm pulling atherectomy and IVL. And if you have it and you have something that's open, rotational, orbital, what have you, you can run it first, right, prior to IVL. Another question was explain better the device feedback mechanism. So the console feedback, it gives you, it's really nice actually. I mean, obviously you can look at your inflator and figure out your atmospheres, but it gives you a digital readout of your atmospheric pressure, which is kind of nice because you get real-time feedback. And they say try to deliver it below 4 atmospheres if you can. So you bring that thing up to 2 atmospheres usually to start, just to get wall apposition, but you'll see that drop, and so you get nice feedback in real time. And the pulses, it's very clear on which emitter, and the pulse is actually really nice. I'm actually impressed by the interface. It's simplistic, but it's nice. It's nicely done. I don't know if you guys have anything to add on the interface. One other question I'll take real quick. Do we know how the laser wave, the cavitation bubble we're talking about, differs from the shock wave acoustic wave, and how are the forces measured? Are they more or less? I don't know the exact atmospheric pressure equivalent, but I will say that in speaking with some of the Boston Sci, engineers, it's at least as effective as the atmospheric pressure equivalent as shockwave, but it has, because of the laser generation, it has the potential to go like exponentially higher. So it's not there yet, probably because you don't want to make something, you want to get FDA approval, you want to get to market. But I think it has, the technology has the ability to go exponentially higher than the current IVL.
All right.
Take it away.
Thank you. Well, that's perfect layup, actually, because that first question about the calcium is actually what I'm going to talk to you about here. So I also am going to present a case, but this case is like a combination of everything. I think sometimes when we do these panels, obviously, we are here to talk about SEISMIQ and introduce this technology. So then what we end up doing is sort of talking about things in a silo. But that's not the case for the patients that we see. What we're really seeing is this patient with all kinds of problems, and ultimately the goal, so here in my 84-year-old, was I had to heal this wound. So I had an 84-year-old lady who had HIT, and she was on warfarin for atrial fibrillation. She had all the standard stuff that we see as vascular surgeons, ICs, IRs. She had kidney disease, and she had this persistent wound. It had been over a year. They had tried multiple debridements. She was doing the classic, 3 times a week, going to see someone as an outpatient, and this thing just wasn't healing. And ultimately, finally, after a long circuitous process, she ends up in our vascular surgery offices. We got ABIs on her because that wound, as you saw, kind of on the gaiter area to the front of her leg, people would start to think venous, right? Because it's not on the foot necessarily. So there probably was a venous component. And that was really the big question. But before we can do anything for a venous wound, which really involves basically compression, you have to make sure that the arteries are okay. So this is what her ABIs were. They're terrible and crap. Immediately start thinking, is it venous, arterial? Is it both? It's always both, because why would I be up here showing you this case? And so the first thing was, well, before we're going to think about anything for that wound, and when we're thinking for that wound, what we're thinking about is potentially vacking, skin grafting, all these sorts of crazy things, plus compression. So we're not going to do any of that if she's not got good flow. And the reason I'm even starting out the conversation, spending a minute on this, is because that's how we approach these patients. And if you don't think of all the tools that can give you something durable, then ultimately it's going to be a worthless angiogram. And, even when I was training back in the day, we would be like, angiogram, amazing, great flow, high five, and that has completely gone away. Even the FDA doesn't care anymore what your angiogram is or even what your patency is. They just want to know, is the leg attached to the body a year from now? And that means that all of these things have to line up appropriately. But one of the biggest things these days is moving away from what does it look like at the end to what does it look like a year from now, 6 months from now. And so doing that vessel prep, which is really what we're talking about, is the name of the game. So I just want to show you a couple of images of this terrible situation. So starting out with, this is her, for those that may not know, because it looks so horrible, that's just her profunda and there's no SFA. And then it comes back, basically right above the knee, but then she's got all this multi-level calcification all the way down into the TP trunk and then all the way into those tibials. As we're going down further, this is just on the diagnostic here, so you can see that really one vessel runoff purely that feeds into this foot. But remember where her wound is, right? Wound is, I'm not chasing the foot here, wound is on the leg. So that one vessel would be sufficient if I were to get good inflow to this, right? So to start out with, went at it antegrade. You saw I would go up and over. I personally do a lot of up and over, especially if the patient has a lot of calcification in the groin because it's difficult to get that pushability. Or I'll do a ENDART, but in somebody this old, you want to obviously avoid, and with a wound, right? Who wants to deal with that groin infection? So went at antegrade, and just as was mentioned earlier, those major crossing heavy tip wires to really try to stay as much as you can interluminal. But obviously here we're in and out in multiple segments, which is why, again, using something that's going to now give you a good luminal gain is important. Ultimately did get through antegrade, coming from the top, which was great. And because I didn't want to mess with that one vessel runoff. Of course you can do it, but in this lady, I would prefer if I, couldn't get through this, that I would have brought her back another day and tried again coming from the groin. But regardless, got through. And then the fun starts. So nothing else would track after this, nothing, right? So I've got my wire, and that is the worst when you have your wire down and nothing tracks, because now what are you gonna do? And luckily I've had rare situations, especially these days, where I've been unable to then get some sort of atherectomy device through. So what I use and what I'm really partial to is the laser, specifically the Orion laser, which I love, just to get that luminal gain, to then do things like, in this particular case, shockwave, because we didn't have SEISMIQ. But the reason I brought this case up, even though we didn't use the SEISMIQ, is to point out how beneficial it would have been in this situation had we had it, because there were multiple chunks of calcium, as you saw, all the way down. And there is a lot to be said. I mean, I got to tell you, that thing about the pushability and being able to track is really key and is difficult in shockwave, not to mention the inability to use it in multiple segments. It is slightly longer. The longest one is 80 versus 60, but being able to really target some of that nodular stuff would have been key here. Ultimately, what we ended up doing is just passing the laser in that area multiple times with bigger and bigger lasers, and then used shockwave all the way through. And then after that, Eluvia stenting. And what we did is DCB at the top and Eluvia stenting down below. I used to be much more scared to stent when I had one vessel runoff, but when it's got that good outflow all the way to the foot and those collaterals, and if I know that I'm gonna have durability, because I use the DCB up top and down below where you saw the popliteal segment, I didn't put anything in that pop, even though there was some stuff there, because I didn't want to have a situation where everything thrombosed. I know that the DCB is going to last for me after I've done decent vessel prep. Then I know that I'll be able to get away with putting a stent in. And specifically, I'm not trying to win a Nobel Prize here. I just need 200 days. 200 days of good blood flow, this is documented, published, to the wound in order for it to heal. So once I got this flow and knew that with the DCB, with the Eluvia, and with the vessel prep, with shockwave specifically in this case, but obviously SEISMIQ would have been ideal, I now was able to do something for that wound. And so sure enough, post-operatively, you can see the waveforms change significantly. She now had inline flow all the way to the foot, and immediately in the same hospital admission, we took her for a wound debridement, got out all that chronic garbage, took her for the skin graft the following day, and then used AOTI, which is basically at-home oxygenation that pushes into the wound to heal it. She has actually healed, but the crux of all of this and all the drama I'm showing you on the screen was that vessel prep and ultimately being able to get the flow at least open for that period of time. Thank you so much for your time.
It's an awesome case, and I think it's a great highlight of and you made a really important point at the start, which is just like when you have a mixed arteriovenous wound, there's nothing you can do until you can compress. And if you can't compress, you're done. And so that's awesome. What's your experience, by the way, with the oxygen delivery? We all were intrigued by this.
It is so awesome. So, if you think about basically historically for wound care, right, we've used hyperbaric. And hyperbaric sucks for many reasons. Patients don't like it. You have to get it covered. Obviously, I think the biggest thing about it is that you can't go to the place. I do believe it works. I do think that if you can do it properly, it does work for the right patient, specifically the diabetic wounds, that type of patient. But it's a challenging thing. What these guys have been able to do is basically the patient goes home with a boot, but the boot has humidified oxygen and has compression. So it does the two things. So it's amazing for venous wounds and it's amazing for arterial wounds. And the best part of it is they don't have to take their bandages off. It goes through the bandage. So they literally stick their foot in it, turn on Netflix, and it just does its job. And there's no like too much oxygen. You could do it constantly if you wanted to, but you should use it. And it's reimbursed. That's right. There's actually 5 randomized controlled trials that have been done already on AOTI that show that it works. But CMS, as you know, is a little bit, they've been scared recently. So we're still in the process. And when I say we, I don't get paid or anything by them, but I go to these CMS meetings to talk about it because it works so beautifully. But the biggest thing about it is that the patient compliance is so high. And then from a scientific standpoint, what's cool about it is when these patients get wounds, the biggest problem is what? That this lady is going to break down her wound again within the year. Venous wounds always, because the stuff that forms over the top of it to heal has only like 40% of the strength of your normal skin. If you get a wound right now and you heal, it's 80% max that you can get, the fibroblast to work and the strength. The beauty of this oxygen therapy is when they look at the stability of the wound, the actual stability is better. So the recurrence rate is 6 times lower than a patient that just gets a random wound healed with just our regular treatment. So the fact that it doesn't recur and the fact that it works is enough for me to use it for every patient because it can't harm anything and it reimbursed like you mentioned.
A couple of things. Beautiful case, by the way. And I really commend you for leaving that BTK lesion because, it's enemy of good is better. And that only comes with experience. I tell my fellows, one of the things that I'm going to teach you this year is when to walk away. Because, you do this beautiful SFA, everything goes well, and then you did that BTK, which you didn't plan on doing it, and it does that. So, and you've already increased that pressure, so beautiful. The other point, I haven't used the Orion laser, but I would say, I know you use a lot of rotablator. I wouldn't mind using a rotablator in this situation where you have the front cutting. If you can't get anything through, you can just put in a wire. So because of that front cuttings, spin at 180,000 RPM and just kind of pulverize that plaque. So, but I'm looking forward to using the Orion laser, I'm sure.
The thing about the iron, and this might all be in my head, but the whole idea behind is something like cutting, I would be scared it would embolize that one vessel, versus the iron is just to get whatever. Then I usually follow with a Serenity balloon, get a little luminal gain, then the shockwave, and then the stent.
Before we close up, one last question from the audience was any situations where the panel thinks being a little more aggressive with blades up, when you were talking about Jetstream, is more appropriate and has improved results?
Ultimately, with Jetstream, from my experience, if you have a relatively, what's your goal? I guess the question is, what's your goal? If your goal is to create lumen gain, to be honest with you and be fair, blades down has been doing a good enough job for me to get through. Now, if I want to be more aggressive and I want to create more of a channel, you go blades up. But I think about what are my outflow vessels looking like. I'm thinking about, okay, well, how aggressive do we actually need to get? What is our goal? Are we going to stent? Are we going to do a DCB? There's a lot of thought process involved when I'm doing this. Ultimately, when I go into a case, my goal is always, I go into a case typically saying, leave no metal behind. That's my algorithm going in, and then it changes quickly when I get in, right? But I'm just saying that I think blades down does a great job, but if you want to get more aggressive and get more of a channel, blades up.
Yeah, I agree with that. And I always feel like the Jetstream will tell you if you can go blades up. So, if you pass through several times and you're still getting bogged down, because it spins at 70,000 RPMs, but if you're really starting to get bogged down every single time that you pass it with blades down, then you're not going to be blades up. But if you do a couple of runs with blades down and you don't hear any of that, the device bogging down, then I think it's worth it to go blades up.
I'll add one other thing, and it's obviously off-label because they don't have an ISR indication, but that being said, in an ISR situation, that's something where I love going blades, you go blades down a couple passes, blades up a couple passes, you got that rubbery, fibrotic type, smooth muscle neo-intimal hyperplasia. It debulks it nicely, followed by drug. I would say anecdotally, but I don't know how anecdotal it is after hundreds of times of doing it, but it works really well to then marry that with drug as opposed to something that doesn't debulk. There's other devices out there, Rotarex and laser and stuff, but maybe you don't make the lumen quite as big and then you follow with drug. In my experience, doesn't quite last as long. So that's one area where I would do it. Well, we're going to be respectful of everyone's time, and so I want to thank our panel for fantastic cases, and thank you all for attendance and interest. And thank you to Boston Scientific.